be recorded. So if anybody needs to go back and watch any of the explanations at the end for the answers, those will be there, as will the actual timed exam. So first of all, thank you everybody for coming. Mosin, if you don't mind going to the next slide.
Yeah.
So this is how long we've been doing this for. It's been since the 16th of October and we're now at the 15th of January. So it's been a lovely 3 months having all of you come together for this. I think it's been a really nice proof of concept that providing free resources that go across universities attracts lots of engagement and invites in lots of collaboration. So if any other university students are on this call and want to do similar series or collaborations or stuff with Manchester to like get each other through exams, make one of the best doctors we can be, that would be amazing. And then if you don't mind clicking, Mosin.
Yeah.
And this is the other stuff we've got coming from Manchester MedEd. So we collaborate with Scalpel, which is the UK's biggest surgical society at our university. And we've done a teaching series going through the UK MLA content for each of the surgical specialties. We've also done an infectious diseases series that's on our YouTube, so you can access both of those. And then in response to a lot of people's feedback on the forms from this series, we're going to do some OSCE focused sessions. Those are already designed by our resident doctors team and we'll be starting those imminently. For Manchester, we've got our exams 11th of March, but anyone at other universities, you're very welcome to join as well. And then in terms of today's session, I don't know if people want to have a play around at the bottom now, just navigating back 2 slides and then syncing back up with us. We're going to time it as 2 minutes per question, so you can see it in the top left of your Teams call, what time we're on. But the idea is that will be the pace we'll go at as presenters. But if anybody needs longer time for example, like a prescription review or less time for a drug interaction or something, then you can navigate back and forward through the questions. So if we go too fast, you guys still have control to look through the slides yourselves. Just don't go past slide 35. I've put a bold slide saying this is where answers start so that you don't give yourself any spoilers. But you can go through the exam at your own pace, and when you're done, you're done. And if anybody finishes really early and just wants to get the thing done and then do their answers, they can. But when it's an hour post starting, Mosin will go through all of the answers to the paper as well with explanations. Some of them have them on the slides already, some don't. So we'll be going through those verbally at the end. Hopefully that makes sense to everybody. If anyone's got any questions, please put them in the chat or any technical issues and we'll try and get on them. But otherwise, I think if we say we'll start when it turns like 7:05, Mosin, I think that'll be good.
Yeah, that's fine.
people.
Yeah, makes sense.
Brilliant. Okay, we've got one thing in the chat. Is it a problema? Sorry, how do I access the slides for the mock? So they should already be shared on your screen. So we will be flicking through them for you. And then you should also be able to navigate through them because we're doing PowerPoint live. So we'll start the mock now, if that's okay, Mosin.
Yep.
Okay, everybody, that is the end of the exam. I hope you found that useful. In response to feedback from last week's summary session, a lot of you had said, please don't use the BPS resources. There's some of our only free ones. And other people had said, please can the doctors just make their own? So they've all put their heads together over like the last few days, even with being on call and on nights and new rotations and stuff, and got this made. So I hope it was useful. Mozen's going to go through the answers now. Chat is open to anybody to ask questions as everyone's had a good go now. So yeah, ask away. This is your opportunity. And I put feedback form in. If you pop your emails in, I'll try and get slides out to everybody as soon as possible. Recording will be available in the Teams chat. And any other queries, please email manchestermeded@gmail.com. And then we can hopefully help anybody with any questions or problems that they're having. And I hope that sounds okay. You
Hi.
want to?
Yeah, I'll run through the answers now. So we've got the questions again on the slides. With the answer and an explanation. I'll just go through them. If anyone doesn't understand something, just pop it in the chat and me and Charlotte will try have a go at answering your questions. Right, so for this first question, you're being asked to prescribe thromboprophylaxis for this patient. And the key thing to kind of get from this question is that she's had surgery, so she's post-surgery. So, and it's following an orthopedic procedure as well. So you can look at the BNF indications for thromboprophylaxis, and you can go with any of these options. So you can go with enoxaparin, 40 milligrams every 24 hours. Dalteparin as well can be used, or unfractionated heparin might get you some marks as well, but it'll be reduced marks because in this case there's no renal impairment. Tinzaparin could also be an answer. There's other options as well. By the way, the all options aren't listed. Just like the top like two or three. But Tinzaparin looks like it'd be an acceptable answer as well. So you've said patient why is no renal impairment if the patient has reduced creatine? Well, essentially in renal impairment, you'd see that raised rather than low. For orthopedic procedures, it'd be 40 milligrams once a day. Just gonna go to the next question. I'll try answer some of them and circle back to them, but for the purposes of time. So the next question is about hypoglycemia. Essentially, now if you look on the BNF, there is a treatment summary section for hypoglycemia that will show you what to do. In this case, you're already told that we've tried glucogel and it's not worked. So the next option would be either glucagon or glucose. So the number one option here would be intramuscular or subcutaneous injection of glucagon 1 milligram, and you'll find that on the BNF. Secondly, you could do it an IV infusion glucose 20% 100 mil. Additionally, you could do glucose 10% 200 mil, but that would be reduced marks just because it's not the most ideal option when you've got a 20% 100 mil. It's less fluid, it'll take less time to go through. So in this next question, you've got a picture of gout. In terms of other differentials you could have been thinking about, septic arthritis, but you've not really got a temperature here, patient stable, and you've not got that like classic red hot swollen red picture. So Yeah, you could go with 500 BD. If it says the range, then it will be the range. So any of those answers would be acceptable but for just for this, we've put down colchicine. Um, it also says on the treatment summary for gout on the BNF that you can use NSAIDs and prednisolone, but in this history, we've got history of um, like gastritis or esophageal problems. So usually the marks are out of. We'll sort that out in a second. Due to history of ulcers, so it's not recommended in this case. So NSAIDs and prednisolone would not be recommended in this case. So the next question, you've got a classic history of like hyperemesis gravidarum. In this case, the main thing to highlight is you can use any of these antiemetics, but the main thing would be to the route. So make sure you go with the intramuscular route if you're giving antiemetics to someone who's constantly vomiting. Because if you give them orally, they'll vomit it back up and it won't have time to work. You could use chlorperazine. Other antiemetics would be correct if, yeah, chlorperazine IM is an option as well, as long as you got the route as IM. That would also be a suitable option. Cyclazine IV can be given too. So in this next question, it's a fluid prescription. Now, just to note, there's a bunch of different answers that you could have given for this one, but we're just going to go with this answer for this question. So we're told that they've in hospital for an elective procedure, so they do their maintenance fluids rather, so it's not a resuscitation, or we're not replacing any fluids. Can you give chlorpromazine rectally? I mean, it's not the most ideal option. It might get you reduced marks, so you might have the correct drug, but you might lose marks for the route. So in this case, we're already told that they've given a bag of sodium chloride and glucose 12 over the last 12 hours. So they've already received 1 litre of fluid and they've already received their glucose requirement for the day. So they're still missing their potassium and they still do another 1400 ml of water. So the best bag to give in this scenario would be sodium chloride with potassium chloride 0.3% in it. So that would give you like 40 millimoles of potassium, and it'd give you a litre as well. Would you get any marks for putting 0.3% KCl with 5% glucose? So you would get reduced marks. So we've already given them their glucose for the day. So you wouldn't really give any more. So you might get reduced marks for that. You could do 0.15% KCl, yeah, that would be acceptable as well. So in this prescription review, we're asked to select two medications that are most likely to cause increased risk of falls. So in this case, amitriptyline is anticholinergic, has an anticholinergic effect, so that can increase your risk of falls. And ramipril is an antihypertensive, and that can increase your risk of falls as well. In terms of medications that are likely to have increase her risk of fracture, if you look on the BNF for both of those drugs, you'll find that a fracture as a side effect for omeprazole and prednisolone. Yeah, these ones in the exam would be out of 4. So the next question is, two medications that should not be prescribed during pregnancy. So the correct answer here would be apixaban and bedroflumethiazide. They're both unsafe in pregnancy, and you can find that in the pregnancy section of the BNF pages for both the drugs. But also you can also use amlodipine and prednisolone, but it's a risk-benefit basis. Those are commonly given in pregnancy, so those are usually okay. In terms of medications which might contribute to deranged glucose level, thiazide diuretics can cause hyperglycemia, and steroids can cause deranged blood sugars as well, and you'll find those both listed as side effects in the BNF as well. And then we're asked to select 3 prescriptions that are inappropriate for Mrs. Roberts, considering her age and medical history. So glibenclamide is a long-acting sulfonylurea, and sulfonylureas are associated with high risk of hypoglycemia. And if you check the stem, she was hypoglycemic on admission, so that would be inappropriate for her at the moment. Chlorpheniramine should be avoided in elderly patients with dementia because it increases risk in elderly patients with dementia, and it also has an anticholinergic effect as well, so it can increase risk of falls. Lorazepam should be avoided in the elderly as it can increase risk of confusion and ataxia, and it can lead to falls. Again, anticholinergic effects. And in terms of prescriptions that have been likely prescribed inappropriately, trimethoprim is not really an appropriate choice of treatment since the urine dip was negative for nitrites, which rules out a UTI, and it can also contribute to the development of hyperkalemia. Right, 1 second. Sorry, I don't know why the tick's on ramipril. It should be on sulfazine, but sulfazine can cause yellow orange discoloration of the skin. And if you look under side effects for sulfasalazine, you can see it says skin reactions. And then we're asked to select 3 prescriptions that are most likely contributing to sleep disorders. So in the side effects sections in the BNF monographs for these drugs, you can see sleep disturbance in the side effects. So beta blockers can cause sleep disturbances. Steroids such as hydrocortisone and prednisolone can also cause sleep disturbances. And tricyclic antidepressants can cause sleep disturbances as well as it affect the central nervous system. So in this question, we have a 22-year-old lady who's presented with severe asthma. In this case, the most appropriate option would be to give repeated nebulized salbutamol driven by oxygen. As it's your scale 1, she's saturating under 94%. For the other options, it tells you why they're not the correct option. So there's not for A, so starting oxygen and doxycycline, there's no evidence of an infection at the moment, so antibiotics aren't required at this stage. For B, IV mag sulfate would be given with senior input, and it'd be given after you've tried all the other options. Again, same with D, and E is more longer term management rather than acute management. Yeah, sorry. Just to echo what Charlotte's saying, sometimes you'll find questions where it's one will be like common or one will be like very common, and you kind of just have to use your clinical intuition to go with the right answer. It's not ideal, but occasionally you will have to pick between two. So here the answer would be D because a fluid bolus is required as he's hypertensive and tachycardic. 250 ml is more appropriate than 500 ml, especially in elderly population where you're more at risk of fluid overloading them. So that's why 250 ml would be the correct answer in this case. I know we're taught 500 ml commonly as a fluid bolus, but especially in the elderly population, it's usually 250 ml. And then you can try another one if the blood pressure's not coming up. Um, I'd say for age over 60, 65, what is mostly is situational judgment in this case. He's frail, and in the elderly population, often if you give them too many 500 ml boluses, you'll overload them and cause further problems. Next, we've got a clinical stem of DKA. In this case, the most appropriate initial insulin prescription would be fixed rate insulin, is what we usually goes for. The answer's A. So for question 13, we're given a picture of a lady who's presented with community-acquired pneumonia, and she's got severe pneumonia. If you go for the treatment into the treatment summaries for high severity, it says colmoxiclav and clarithromycin. So that would be the correct option. Oral amoxicillin would be appropriate for low severity CAP. Doxy would be used if there's penicillin allergy. These more of a broad spectrum antibiotic, and clarithromycin doesn't usually cover typical organisms. So here you've got a question about what must the following must be present on the prescription for it to be valid. For controlled drugs, you need to have the prescriber's signature. It must be handwritten, and you need to write it on paper. So again, you're asked to provide the piece of information that's most important to the patient. So for isotretinoin, it would be the pregnancy, because there must be support in a pregnancy prevention program due to the teratogenic effects of isotretinoin. So yeah, in this question, it'd be about breastfeeding, because tetracyclines shouldn't be given to women who are breastfeeding because it can cause discoloration of the teeth. So moving on to the calculation questions, it's important to extract the useful information for from the information you provided. So we're told the loading dose is 12 milligrams per kg. So we can times that by 68 to get the total loading dose. Sorry. I'll come back to some of these in a second. Charlotte, sorry, I'm having some my thing's frozen.
Yeah,
Would
okay.
you be able to continue?
Yeah, of course, of course.
1 second.
Okay, so let's just keep going with
1 second.
I think your slides are stopped, so hold on, let me just share on mine. Sorry guys, just give me a second. It's just setting up, sorry guys. Have we lost Mosin? Oh. Okie dokes. I think Mosin's having some technical difficulties, but what I will do is I will whiz forward to where we were. I think we got up to the first calculation question. And then I can just talk people through answers. Can people see this okay? Can somebody just please pop a thumbs up in the chat or like a little react thing if you can see it okay? Amazing, thank you. Okay, so which one had we just done? We've done tachyplanin, I think. Oh wait, we're not at answers, we are at questions. Sorry guys, just give me a tick. Okie dokes. We just did this one. Okay, and now moving on to the question on the patient with their target INR. So they need a new daily dose of their warfarin. So they need to basically have an increase in line with BNF guidelines. So they've recommended 10%, so they're on a dose of 5. 10% of 5 is 0.5, so you just add on the 0.5, and then you get their daily dose. So easiest way to do that, 7 days in a week, divide 35 by 7, you get, yeah. Well, I personally probably wouldn't have done the full weekly dose because it should theoretically work out the same if you increase by 10% on each day. But yeah, any questions on that one? Yes, can see. Oh, thank you, Lily, for answering in the chat. Yeah, scarily too simple, got me stumped. Yeah, I think there's 2 ways to do it. There's a couple of those that they do on BPS as well, where you can go the long way around or just straight line. And I think it gets you back to the same thing. Question 19 was about an aminophylline infusion. So the recommended doses is 0.5 milligram per kilo per hour. They're supplied at 250 milligrams in 10 mils. So just going through this question, when I did it, I just calculated how many milligrams they needed per hour. So they needed 30 milligrams. And then we know that it comes in 10 mil samples, but it's tricky to work with 10 mils. So just say how much is that per mil? So they've got 25 milligrams per mil. So you can do 30 divided by 25. I didn't have a calculator with me, so I just said if 1 mil's 25, then 0.2 mils, which is a fifth, will be 5 milligrams, and that makes my 30. So you can just use 1 plus 0.2 mils per hour. But you will have a calculator in the exam because unlike me, you will bring the stuff you need. So hopefully that one makes sense. And then in terms of the Parkinson's meds, so if you did the full calculation, for the 125 milligrams, you would get to a 10 milligrams in 24-hour reticotine patch. But just for the safety of dopamine side effects and doses, you go with the sort of safest conversion, which would be an 8 milligram patch. And just to clarify on this, Catherine has included a Parkinson's Meds MedCalc link so that you can go and read more on that afterwards. Okie dokie. I'm hoping Mosin will be back soon because I'm shooting in the dark here. But most of these, I hope, are quite intuitive. Paul, I will get back to your warfarin question in a sec, but pop it in the chat. I'll keep going through and then we can hop back. Okie dokie. So, yeah, swollen ankles. We've got a list of drugs, diclofenac. We've got ARBs, methotrexate, sulfasalazine, but there's a calcium channel blocker in there. So hopefully that's a nice one, just a bit of knowledge that you can just tick off and go through. But puffy ankles, calcium channel blockers. The next one, so they were quite nice in this question. They said about what he's taken. So he's got a bottle of diazepam very handy next to him that's empty. So he's overdosed on benzodiazepines, but for future, if people want to find this in the BNF, if you type in poisoning, it goes through overdoses of all of the different options. So you've got your paracetamol overdoses, your like salicylate, so aspirin overdoses, TCA overdoses and everything. So you can go there and it can give you like a quick summary guide of what you need to dose them with. So in this case, it's a benzodiazepine overdose. So flumazenil. They did mention that it's potentially hazardous if it's a mixed overdose, but just by the nature of this question, it's other medicines have appeared untouched. So it's kind of like hinting, don't worry, it's not a mixed overdose. Okie dokie. So next one is we've been given some blood test results, and on admission, patient had raised sodium. It's improved slightly, but the main one that has changed is they started on a normal potassium and it's approached hyperkalemia now. So they've got a list of medications and they want to know which one increase the risk of hyperkalemia. So Neoral is the brand name, but that actually is cyclosporin. And for anybody who wants the sort of quick hyperkalemia guide, if you go on Appendix 1, and then you Control F hyperkalemia, it's got the list of all the drugs. And if it's not in there, because it's not an exhaustive list, you can use the and/or function that Mosin showed us in session 2 on elderly care. But essentially what you do with that is you type in the side effect, like hyperkalemia, put and in all caps, then you say like which drug, you put a bracket, and then you put the first drug or second drug, or and then you do that, and then you end bracket it and you enter, and it should come up with if they have hyperkalemia listed in their side effects, just as a BNF guide. I would be sharing all of this on the screen, but then I think you guys might lose the PowerPoint, and I'm sorry. Okie dokie. So diabetic medications review, a lady who is on short-acting Novorapid in the day, and then she's got a Lantus 14 units that she takes at night. So if you're giving somebody a long-acting insulin at night, it's working overnight. So the next time you want to check if their blood glucose control is good will be in the morning. So you check before breakfast, before they've had any glucose in their system, to see if you're actually achieving that good basal rate you want overnight. Pre-dinner, pre-lunch, patients will check, or if they've got a monitor on their arm, they'll check, but it's not really as necessary for that basal dose they're taking before bed. So check before breakfast. Where is this info in the BNF? So I don't know. So when it says her dose, yeah, that should say Lantus dose. Thank you for pointing that out. Yeah, we should have specified that it would be increasing her Lantus dose, but I think in terms of what you adjust with diabetic medications, you do like I think it's a 10 to 20% increase. So being very cheeky on the creation of the slides, you can usually extrapolate that the 14 units has been increased by 2, so that's between 10 to 20% increase, whereas the short acting, that would be a massive jump. They'd have increased by like 50%. So sorry, that's bad from us. Should have put I should have written Lantus when I was formatting the slides, but yeah, sorry on that one. Do, 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 do. Question 25. So they've been started on olanzapine monitoring options. I don't know if people have done their psychiatry rotations, but a lot of patients who go on olanzapine do describe that they've got an increase in their appetite. So if you keep a monitor on their weight, that's a common side effect of that as an antipsychotic. And also this class of antipsychotics loves to have metabolic side effects, so keep an eye on their weight and general metabolic-ness. Oh, that is a nasty cough, whoever that is. I'm sorry, I hope you get well soon. Okie dokes. Question 26. Adverse effects of erythromycin. So this is to do with interactions of medications. So when it comes to INR type questions, usually I pop in warfarin, click on interactions, go down to list of drugs it interacts with, and then you can control F the drug options. But in this case, it's more about looking from the other end, so going with erythromycin. So you can also like control F for warfarin. Hope that helps. And then it will usually say increases, inhibits metabolism of warfarin, therefore increases INR. It usually states it quite nicely. But that's just a general tip I've sort of found. When should the blood test have been taken? This is under lithium monitoring. 12 hours after the last dose is when you check a patient's lithium. But again, if you go in lithium monitoring requirements, it's written there. Question 28, most appropriate action. So this is quite a cool one from Casper, just saying that even though they're not scoring in terms of the CRB 65, there's still a really high likelihood of sepsis. In a fit and well person, saturating 93% with a BP of 99/87, think less about the scoring systems, more about the hemodynamic stability. So you still need to immediately get this patient to hospital. If anybody came in with those observations and some new onset symptoms, you want to get them safely seen in a secondary care setting as soon as possible. Question 29, which should form the next part of the management plan. So they've given a guide of vitaminadione, etc. for INR, but what I found really helpful is if you go in anticoagulants on summaries, you can then control F for hemorrhage, and it talks about the patient's INR, and it says about whether or not they're bleeding, and it tells you what you need to do with their warfarin doses, and also if it's necessary for you to administer any vitamin K. So you can search vitaminadione, you can search high INR, or you can go in that way. Either way, it should come up with the answer you need. Okie dokie. Most appropriate next step. Last one, everybody. Started on dalteparin for left-sided DVT. He's on 5,000 units, and they're taking his level that comes back as 0.4. So again, this is one where you can go on the monitoring for the specific drug, and the answer would be that you need to increase his dose to 6,000 units because he's not achieving a sufficient plasma concentration of anti-10A. So that's the action of the low molecular weight heparins. I had to go and read up on this because I get thromboprophylaxis and treatments of DVTs and PEs wrong all the time. But this one's quite nice. It's in the BNF. It's just remembering the names of the low molecular weight heparins. So, groovy gang, that is it. Thank you so much, everybody, for coming to this whole series. And I really wish everybody the best of luck. Those of you not at Manchester, hopefully we might meet each other in FY1. That'd be super cool. Really hope you smash it. And yeah, good luck, everybody. I hope this series has been helpful. Would really, really be grateful if you can all fill in the feedback form, because it would be nice if we could get something out of this series, maybe do something at like an education conference and encourage other people to do free series for mandatory exams like the PSA. So accessing recordings, I think we might just publish everything on YouTube soon. So if you subscribe to our YouTube channel, sounds super stupid to say that, but then you'll be able to get everything. Question 20, yeah, I'm happy to talk about it, Jess. Okie doke, the Parkinson's meds one, is that the one you meant? You're so welcome. Oh, you're welcome. Thank you so much, everybody, for coming. Yeah, so I think there was a few of us. Yeah, so with the Parkinson's meds one, so you've got Catherine's workings on the screen, but hold on. I'll also try and hold my ones up. So basically, you've got somebody who's taking 125 milligrams 3 times daily, and you've been told, so that's like 3 times in the day. They're taking 375 milligrams once daily, but the conversion they've given is for their TDS dose. So they're saying that the equivalence is already for if they're taking it 3 times daily. So you don't need to calculate the 375 milligrams part. You can just do a straight conversion because it's TDS to TDS. So if they're at 125 milligrams, then you want to go the 8 milligram per 24-hour patch will give them 100 milligrams. I calculated for if they wanted that full 125 milligrams, you do another 2 milligrams every 24 hours. But it's about the safe dosing for a Parkinson's patient. You don't want to slap them on a load more dopamine. So the safest, like, close patch of Ramatadine is the 8 milligrams per 24-hour patch. Okay, I'm seeing lots of O's in the chat. Hopefully that's explained it. So any more questions that we can run back over for anybody? It's so much easier to answer these verbally because otherwise it's very hard to type so fast. Okay, great. What happens if we prescribe 10 milligrams? I mean, you'd be giving them an excess of dopamine, and risk of dopamine stimulation, I guess, would be psychosis and psychiatric type symptoms. So yeah, safe dopamine dosing for all. You're welcome. Thank you so much, everybody, for coming. I will stop recording now, but I will keep the meeting open.
Yeah, if anyone, sorry, I'm back. If anyone